Well, it's just absolutely fabulous to be here. A couple of the reasons are that earlier in my career, I was fortunate to be involved in a study that was conducted in Israel by my mentor, Bruce Dorenwin, and also Itzhak Levav, who some of you may know. And during that whole period of doing that study, I was never able to come to Israel. This is my first time. It's also great to be here because I feel, being here, a tremendous affinity between our country, your country, especially my city, New York, and your country. I feel at home here, and I'm really happy to come visit your country. And because of feeling that way, I also want to thank everyone who brought me here. I want to thank Perla Werner, the dean here, for all of her strong efforts to make that happen. To all the sponsors, all the people who work so hard to get the slides and all that translated. And in particularly, my colleague now, David Rowe. David claims to have been my student. I didn't see it that way, really. I knew he was in a role relationship with me, my student. But in a sense, David taught me. He brought me to a different way of seeing mental illnesses, seeing the personal side of mental illnesses, seeing how people who have mental illnesses construct meanings around their illness. This is part of his dissertation that I was fortunate enough to be involved in. So he helped bring me here, and I'm very thankful for that. I also want to apologize for Americans are terrible with their English. That's all we know, sort of. I know one language well. I wish I could come here and speak to you in your language or in some other common language that we could have together. So I want to apologize for that. Also, I'll be showing you slides that are about findings in the United States. I wish, again, that I had findings from Israel. I'm sure you will generate findings like mine in Israel. But I think that what I have to tell you about the United States will tell a story that I think is more generally useful than just to the United States. But you can be the judge of that. Okay, with that as background, let me begin with my talk. Here's what I want to cover with you today. Perla, one of the exceptional things she did is give a very good definition of stigma and introduction to it, but I want to say a little bit about a definition of stigma. Then I want to give evidence from studies of what the general public believes about mental illness, covering 6 decades in the United States. So we'll look at changes between 1950 and 1996, and then changes between 1996 and 2006 when we were able to do an identical survey in the United States. Then I'll talk a little bit about evidence concerning the consequences of stigma for people with mental illnesses. So let me start with this definition issue. And here I'll talk a little bit about this sort of as I came to it. So at some point in my career, I'd been studying stigma, but I never really sat down and thought about exactly how I conceptualized it or thought about it. And what people would talk about when they talked about stigma was different things, I thought. So sometimes people would use the word stigma to refer to the attribute or the characteristic or the mark or the label, and that was the stigma. And sometimes they'd talk about the stigma as being the linking of that label to undesirable characteristics, so it would be stereotyping. They'd use the word stigma. And sometimes they'd talk about stigma as the experience of disapproval, exclusion, or discrimination. So I thought Joe Phelan and I thought we'd review this and think a little bit more about this concept. And we went to the dictionary, we looked up the dictionary definition, and it said it's a mark of disgrace or infamy. We went to Irving Goffman, whose picture you saw a little bit ago, said that it's an attribute that's deeply discrediting and reduces the bearer from a whole and usual person to a tainted and discounted one. And then to Jones, who Perla also referred to, who defined it as a mark that sets a person apart and links the marked person to undesirable characteristics. Now, there was a time in sort of my sphere when the concept of stigma was really challenged or attacked. And some people said we shouldn't use it at all. And if you look at these definitions, you can see maybe the rationale for why people said that. And it tended to be people who had had mental illnesses and were looking back on their experience. And when they saw these definitions, they saw two things in them. One is that there is a mark, and the mark is something that you possess. It's something that you have. It's in you. It is you, sort of, and or at least a part of you. So that's one thing. And the other thing is that you see in these definitions, you don't see the broad-scale discrimination, the setting apart, the keeping out of jobs and social networks and friendships and the like. And so they challenged on those two bases. And one idea was to discard the use of the term stigma. And I decided with Joe Phelan not to do that, but to kind of reconceptualize, rethink through what maybe this concept means. And to do that, we came up with this set of ideas. And we said that stigma isn't any one of those particular attributes that I talked to you about before, the label, the stereotype, or the discrimination. We have words for each of those things. Maybe we can think about stigma as the confluence of all these things. It's when they come together. So we thought about stigma as having these 6 characteristics, that people distinguish and label human differences. And there's tons of human differences all over the place, if we think about all the differences in this room. But people pluck out particular ones for social salience. This is something that we need to tend to, and then it becomes very important. Hey, people have hairy ears, some people have hairy ears, some people don't. It's not a big deal. Some people have red hair, some people have blonde hair. Maybe it's a little deal, but it's not a big deal. So we pluck out for social significance some things. Then if stigma is to be achieved, then we label persons are linked to undesirable characteristics, to unwarranted negative stereotypes for that particular person. A third component then is the labeled persons are viewed as outgroups, as them, not us. There's a separation. They're different from us. In the extreme, they're not really human. This can allow all sorts of negative actions towards people like that. Then there's an emotional context, an emotional component that some people have already referred to, that people who are reacting to people with stigma can feel fear, repulsion, disgust. And the labeled person may feel emotions of shame, embarrassment, humiliation. So there's this emotional component. And then fifth, if this is to be called something, I'm going to call this stigma. It has to cascade down into something where labeled persons experience a putting down, a status loss in a hierarchy, or they're discriminated against as a consequence. And thinking these sets of thoughts led me to also think the importance of power in stigma, that it takes power to stigmatize, that there has to be a power difference between those who want to stigmatize and those who are the recipients of stigma. You can think about it by thinking about people who are on the stigmatized end of some difference. They may have labels, they may have stereotypes, they may see the others as different. In other words, they can also have these first 3 processes about the people who are doing the stigmatizing. But they can't carry it off because they're not the ones that control the jobs, decide about the friendships, accept the dates or not. So that it takes a power difference to pull off stigma. And it's very critical how big that power difference is. It can be either large or small. The other thing about this definition that's interesting, I think, is that you can think about stigma as a matter of degree. The labels can be penetrating and deep, or they can be less so. The stereotypes can be many and about core characteristics of a person's humanity, or they can be less strong. And the label is less strongly connected to the stereotype. The separation can be more or less extreme. It can be relatively mild or it can be complete. And the extent to which the emotions can be involved is also something that can be a matter of degree. And then the extent of discrimination is also something that can vary according to different types of stigmatizing conditions. So that's a little bit of thinking about a definition of stigma. Now I want to take us to results of, this would be in the realm of public stigma. And I'm going to take us to an examination of differences between 1950 and 2006 in the United States. David, you'll give me a warning on my time, okay? Here are the questions that we'll want to answer. Does the general public recognize mental illnesses as illnesses, attribute causes that relieve the afflicted person of blame, express optimism about the outcome of treatment, recommend policies indicating that mental illnesses are illnesses like other illnesses, reject stereotypes of dangerousness and incompetence, show a willingness to interact with people with mental illnesses? And I'm going to start out thinking about the period from 1950 to 1996. There are 2 surveys done during that period. And I want to just point our attention to the fact that there have been huge changes over that period. Basically, one of the huge changes was in 1950, I was 1 year old. And here I am now with all this gray hair. So a lot of changes have occurred. But one, the public is vastly more educated than they used to be. Media, in 1950, very few people had TVs. Now TV is 8-10 hours a week in the United States. Film, the psycho films didn't exist in 1950. The stereotypes in those movies weren't present. The internet, forget about it. We've had a change in how we deal with people with mental illnesses. We moved from a period of maximum institutionalization to deinstitutionalization. There have been dramatic advances in psychopharmacology and psychotherapy. There have been enormous efforts to educate the public that mental illness is an illness like any other. And in the United States, we've had this phenomenon of direct-to-consumer advertising. So there's huge changes that have occurred. And I'm not going to be able to pinpoint any one of those as the factors that's driving things. Rather, we're going to step back and look at broad changes and just see which direction we're going. And we can imagine being very optimistic about this, or we could imagine ourselves being rather pessimistic about this. Optimistic would be answers that people do view mental illnesses as illnesses, that they are optimistic about treatment and so on, that stereotypes have declined as a consequence. A pessimistic view would see the possibility that no, we haven't done that well, that the media is penetratingly us with stereotypes about dangerousness, and things have actually gotten worse. So we can sort of see how we've gone along these lines. So if we go back to 1950 and we develop for ourselves a characterization of what the public thought in the 1950s, I'll just give you a few examples. One is from another one of my mentors, Elmer Struening, constructed this thing that he called Opinions About Mental Illness Scale in the 1950s, and he gave it to the people who worked in psychiatric hospitals, and he found a basis of authoritarianism and socially restricted attitudes sort of underlined how people thought about mental illnesses. A famous psychometrician, John Nunnally, developed opposite adjectives, semantic differential, to describe people with mental illnesses, and found that the way people characterize someone with a mental illness was dirty, dangerous, and twisted, adjectives like that. So strong stereotypes. Coming were a psychiatrist and a sociologist couple, and they said, boy, these attitudes are horrible, and it's been documented by Nunnally and others. Let's go out and try to change it. And so they went to 2 communities in Western Canada, Saskatchewan, and they set up an intervention community and a control community. And they went into the intervention community, tried to change the public's attitudes. It was a horrible failure. Not that they didn't have great ideas, but the public got stirred up and upset about these people coming in and teaching them about mental illness and trying to change their stigmatizing views. And they actually went to the mayor of the town. The mayor of the town finally came to these 2 researchers and asked them to leave because it was making too much commotion in the community, and that they would rather it stop. And so they entitled, the title of their book was called Closed Ranks, that people close ranks, don't even want to enjoy the idea of this concept of mental illness. So that's another example of attitudes in the 50s. And then finally there's this Shirley Starr, a very famous person in the history of attitudes towards mental illness. She did a nationwide study in the 1950s in the United States, the first one in the United States. And we'll use that a bit. And one of the things she constructed, and I'm basically in my research imitating her, is vignettes. And these vignettes were called the STAR vignettes. And I won't take the time to go through this, but she developed a vignette of paranoid schizophrenia. The vignettes were aimed at describing the way the mental health professionals thought about mental illnesses at that time. And so this particular person, you can see that a couple of times now he's been beating up men who didn't even know him because they were plotting against him, and then the other night he began to curse his wife terribly. So this was the description of paranoid schizophrenia. There were 6 of these, and this is another one. I'll only show you 2 of them. Compulsive phobic. She's getting along well, but she always has to go back and check the stove and make sure the door's locked, and she can't ride up and down elevators. So she gave these vignettes to the public, and she asked them, do you think this is some kind of mental illness or not? And here's what she found with the paranoid schizophrenia vignette. 3/4 of the public saw that as a mental illness. But none of the other 1, 2, 3, 4, 5, I have it right, none of the other 5, were even more than 1/3 of the people saw them as mental illnesses. And even that paranoid schizophrenia one, 1/4 of the people didn't think that was a mental illness. This was viewed with enormous, this was not a good thing, and a negative kind of attribute of the public's view about mental illness. Led Shirley Starr to write this: mental illness is a very threatening and fearful thing, not an idea to be entertained lightly about anyone. Emotionally, it represents to people a loss of what they consider to be the distinctively human qualities of rationality and free will. And there's a kind of hard dehumanization. As both our data and other studies make clear, mental illness is something that people want to keep as far from themselves as possible. So this is the 1950s. And if we answer the questions we set out about the 1950s, does the general public recognize mental illnesses as illnesses? No. Star vignettes. Attribute causes that relieve the afflicted person of blame? Well, probably not. We don't have any direct evidence of that, but there are other attitudes suggest it. Express optimism about the outcome of treatment? Not really. They closed ranks. They want to send people away and keep it that way. Recommend policies indicating that mental illnesses are illnesses like others? No. Reject stereotypes of dangerous or incompetence? No. Show unwillingness to interact with people with mental illnesses? No. A pretty discouraging set of circumstances in the 1950s. Beginning in the 1970s and 80s, people began to think differently about what's happening about public attitudes towards mental illness. This is a quote from a guy named Walter Gove. He's saying that the evidence from the 1950s would indicate that the public was ignorant about mental illness, had a very negative image of persons identified as mentally ill, and excluded them. But since then, there has been massive education effort focused on mental illness. Furthermore, the effectiveness of treatment has become fairly visible. So what had happened by 1996? In 1996, we came along and did something is called the General Social Survey. It's a nationally representative sample of 1,444 people living in households in the United States. There were in-person interviews conducted by the same interview group that had done Shirley Starr's study in 1950, the National Opinion Research Corporation. There you see our response rate. It's a collaboration between Indiana University and us at Columbia University. And we constructed 5 new vignettes, 4 of mental disorders and 1 of a troubled person. And the 4 disorders fit DSM criteria, and the troubled person we used as a benchmark. And we randomly assigned in a survey experiment, 1 vignette to each individual in the study. And here they are, and I'm not going to read through them all, but there was 1 for drug dependence, there was 1 for alcohol dependence, there's 1 for schizophrenia, and this would meet DSM-4 criteria. We changed the gender and the ethnicity randomly and the educational level of the person in the vignette, just so you know that. But you can see that he has role functioning problems and classic symptoms of schizophrenia as described in this vignette. And then major depression as the symptoms of major depressive disorder from DSM-4. The classic symptoms of loss of interest in things and depressed mood, and then some social functioning kinds of problems because of the illness. And these are each read to each person, and then they're going to be asked questions about them. Let me spend a little time with this vignette depicting a troubled person, because we're going to compare the disorders to these ones that have the troubled person in it. And this is kind of like me on a bad day. He feels that at times things bother him more than they bother other people, that when things go wrong, he sometimes gets nervous or annoyed. Otherwise, he's getting along pretty well. He enjoys being with other people. and so on. So these are the 5 vignettes. Now we're going to look at people's responses when they're read these vignettes. So the first thing we might ask is, do members of the public recognize and label the vignettes as mental illnesses? And so we asked a question, in your opinion, how likely is it that the person in the vignette is experiencing a mental illness? Is it very likely, somewhat likely, not very likely, or not likely at all? And this is splitting it at very or somewhat likely. Here's what you find is that for the schizophrenia vignette, it's 88%. For major depression, it's 69%. And then you see the ones for the other disorders. Fortunately, you know, the troubled person who really isn't a disorder, 22% thought that vignette represented a mental illness. Now, this is higher percent than Starr found, but not really all that high. We might hope that people would recognize these disorders more thoroughly. But we thought maybe the public had gotten more sophisticated than our terms that we use, and they might not want to call someone mentally ill because of the stigma associated with mental illness. So we asked people, does the person have, and then the thing that we wrote the vignette to describe. So does this person have drug dependence? Does this person have alcohol dependence? Does this person have schizophrenia? Does this person have major depressive disorder? And there you see people do recognize the disorders in a manner that would be consistent with going to seek help for them. So they could give them a name that would then, you know, be consistent with, this is a disorder you might need help for. So this is kind of like a positive change between 1950 and 1996. What about causes of these conditions? So we asked, in your opinion, how likely is it that the person's situation might be caused by his or her own bad character, a chemical imbalance in the brain, the way he, she, or was raised, stressful circumstances in his or her life, a genetic or inherited problem, or God's will? Now you can look at these and you can imagine more stigmatizing kinds of attributions of cause. So bad character, these are his or her own bad character, or stigmatizing of the family, the way he, she, or was raised. And then other ones that would be less stigmatizing, biological chemical imbalance in the brain, stressful circumstances in his life, or genetic, that aren't his fault, his or her fault. So what are we going to find? What do you think? You can imagine now, what do you think would be the main attribution? It was stress. American public thinks stress is important in all of these disorders. And so you see that it was the top one for all of the disorders in 1996. And then if we look at the profile of attributions for different, here's major depressive disorder. You see 95% think stress, 73% think chemical imbalance in the brain, 53% think genetic or inherited problem. The person blaming and the family blaming are lower down in this hierarchy. Same thing's true for schizophrenia. So you see the exact same profile there of. So this is, again, kind of like a positive turn of events by 1996. This is kind of like you can imagine the public having adopted a diathesis stress model. Stress and biological and genetic factors combine to produce the disorders. Now, 45% thinking that the families, the way the person is raised, families may see that as too high still, but it's at least not as high as the others. It's lower down. What about the public's hopefulness about treatment? So here is, in your opinion, how likely is it that the person in the vignette situation will improve on its own? In your opinion, how likely is it that the situation will improve with treatment? So now if you're going to imagine the results going into this, you're going to imagine optimistic results, you'd want to think that for the disorders, that people wouldn't think that it's just going to improve on its own, because that wouldn't lead them to seek treatment. And that you would like to see them thinking that if they go for help, they'll benefit from it. So you want to see a gap between those two lines. Here's what we found. There are large gaps between those lines. The public is enormously hopeful about improvement with treatment. I tell clinicians this, and they're sometimes surprised by this, that maybe they're too hopeful. But you see there that for the disorders at least, the public, the orange lines there, the public thinks that if they go to treatment, the people with these kinds of disorders will benefit from it. And that the green lines there are much lower, all except the one that isn't a disorder, the troubled person. So there's showing a kind of sophistication and hopefulness among the public. So again, this is kind of a positive change between 1950 and 1996. Is everything great, changed in a great way between 1950 and 1996? Not at all. Here is, we asked them, how likely is it that the person in the vignette would do something violent towards other people? And here you see a stair step starting, and this is one of the reasons we put the troubled person in. You see the 17% think that the troubled person who doesn't have symptoms will do something violent towards other people. You read the symptoms of depression. I didn't give you a chance to really look at them closely, but there was nothing about violence in there, just the symptoms. It doubles. Read schizophrenia, it's about 3 times as high. These are enormously high, very strong connection between hearing the symptoms of these disorders and making an inference that the person is likely to do something dangerous. And this, here's whether or not you would be willing to have the person as an acquaintance, a friend, neighbor, coworker, or an in-law, sort of, are you above the median in your willingness to have these relationships? You see the exact same stair step, relevant to being willing to interact with a person. And a strong driver of the social distance is the fear of danger. So in the back there are people who believe that the person's likely to be violent, and their social distance, it's substantially higher than the social distance desired for people who decided that the person wasn't likely to be violent. So violence drives social distance. That social stereotype's critically important. And you can stop here at 1996. It's kind of a negative attribute of the public at that time. What about how have we been doing over time with this since 1950? We had hoped to be able to compare things between the 1950 survey and the 1996 survey. We couldn't compare many things because they just talked in 1950 about mental illnesses very differently than we do now. But here's one question that we were able to replicate, and it's an open-ended question. Of course, everyone hears a good deal about physical illnesses and disease, but now what about the ones we call nervous or mental illness? When you hear someone say that a person is mentally ill, what does that mean to you? And we developed sets of codings based on how people, then that was, all this was written down verbatim. We developed a set of codings about how people responded to this. And we categorized them as to whether or not they, in their minds, they were thinking about something that was like a psychotic illness versus other illnesses. And we also made codes as to whether or not they mentioned anything, spontaneously mentioned anything about violence. And then this is what we found from this. So what you see in the green bar here is from 1950. We were able to directly replicate this. And then the orange is 1996. And what you see here is if their conception didn't involve psychosis, they didn't say anything that suggested that their conception of mental illnesses included psychosis, they were substantially lower in reporting, spontaneously indicating anything about violence. If they didn't, in 1950, if they did have a conception of psychosis, substantially higher in terms of violence. And the same thing was true in 1996. But the really dramatic thing, going forward from 1950 to 1996, is that in 1996, a tremendous increase compared to 1950 in spontaneous mentions of violence associated with psychosis. So it's not just that things are bad, it's things that have gotten, looks like things got worse from this evidence between 1950 and 1996 on this critical component of the stereotype of mental illness. So if we characterize 1996 now, does the general public recognize mental illnesses as illnesses? Yes. Attribute causes that generally relieve the afflicted person of blame? Generally, yes. Express optimism about the outcome of treatment? Definitely yes. Reject stereotypes of dangerousness? No. And show willingness to interact with people with mental illnesses is limited by a fear of violence. So now let's go forward 10 years more to the 2006 General Social Survey, where we exactly replicated the 1996. So this is a nationwide survey that's identical and done by the same research group. It's another collaboration between Indiana University and Columbia University. It's about the same sample size. This time we used the exact same vignettes, but we cut one out. We cut out the cocaine dependence vignette. We had 4 vignettes, and we randomly assigned one to each person. And so we can see then how have we done in that 10-year slice of time. With respect to identification of disorders, here's what we found. Almost the same. It was high to begin with, and people still recognize the disorders about the same. So that was good in 1996, remained good in 2006. Stressful circumstances remained important causal attributions of the causes of these disorders. If we then start to look at things like the other causes that we asked, one of them was chemical imbalance in the brain. Interestingly here, pretty substantial jumps for most of these disorders between 1996. So the public is beginning to believe more than they used to that mental illness is caused by a chemical imbalance in the brain. What about a genetic or inherited problem? Again, a substantially increase in the general public's belief that mental illness is caused by a genetic or inherited problem. Some of you may want to keep track of the troubled person. You'll see that the people are more likely to attribute genetic causes to the troubled person too, which is an interesting finding. It's not like every attribution of cause went up though. And here if you look at the way the person was raised, the orange bars versus the green bars, it dropped for schizophrenia and for major depression, went up for alcohol dependence. Here's our own bad character. Not a lot of change there. Interesting, the alcohol vignette, a pretty substantial increase over that period of time. What about the necessity and hopefulness about treatment? This is a busy slide, but again, we're looking at the gaps between you believe it could improve on its own and you could believe that it improved with treatment. And the first 2 bars are the 1996. The second 2 are the 2006. And you see there that the hopefulness about treatment has remained. If anything, the gaps are getting even larger. This goes down, this goes up, this goes up, this goes down. What about medical and psychiatric treatment seeking? Substantially, the public has increased its belief that it's be a good idea for people with these disorders to go to a medical doctor for help. So increased support of help seeking for all of the disorders, pretty substantially so. Seeking help from a psychiatrist, the same result. The American public believes these disorders are something that should be seen by a psychiatrist. Taking prescription medication for the disorders, also increased support. You might also see that it occurs for the troubled person as well. And then what about something like, does the public believe that the government or insurance, as opposed to the self, the family, or charity, should be most responsible for cost of medical care? Substantial increase in the public's endorsement of insurance and the government paying for the care of the disorders compared to the family or charities. So this is a pretty substantial change towards parity in the United States. And then the changes from 1996 to 2006 concerning causes of the disorders and recommendations of medical and psychiatric treatment were very similar across gender, educational levels, and also age. So it's not those changes I showed you about chemical imbalance, about that the causes are inherited, genetic or inherited, were shared by different demographic groups in the population, men and women, old and young, highly educated and less highly educated. So the results are suggestive of a broad sweeping change in public attitudes in the United States. And it also turns out, this is a slide not from our study, but from 3 different psychiatric epi studies done at different periods, the 1980s, the 1990s, and 2000. These are people who have one of the disorders as determined by the psychiatric epidemiology population-based study, and whether or not they had sought treatment for that disorder in the period assessed by the instruments. And you see that in 1980s, 19% of the people with disorders went. In the 1990s, 25%. By the early 2000s, 41%. So that these these broad changes in attitudes that are positive towards help-seeking go along with increases in help-seeking behavior. How have we done about the stereotypes of incompetence and dangerousness over this period? Well, you remember that here's a slide describing whether or not the described person is very or somewhat able to decide about managing their own money. Pretty much no change. So we've changed people's views about whether these are medical kinds of illnesses that are caused by genetic or inherited problems, but not much change in their beliefs about whether the person is able to manage their own money. About violence towards others, no change whatsoever. So again, we've changed some things, but we aren't changing these particular stereotypes. People are just as likely to believe that the vignette person is likely to do something violent towards other people in 2006 as they were in 1996, despite those radical changes I showed you. Social distance, the exact same thing. This is not going away. It's still with us, people desiring social distance from the people with mental illness. And then further, these stereotypes of dangerousness and incompetence and social distance are actually more prominent in people who believe a chemical imbalance in the brain causes the vignette condition, believe that the vignette conditions are mental illnesses, and who recommend treatment from a psychiatrist. So we made changes in those, but these are associated not with better attitudes towards stereotypes of dangerousness and incompetence, but actually worse ones. Here's a couple of examples of this. And this is people who believe that it's a chemical imbalance in the brain. And for schizophrenia, if you believe that it's caused by a chemical imbalance in the brain, 63% think the person's likely to be violent. If the person thinks that it's not caused by a chemical imbalance in the brain, it's 51%. Same is true, but not as strikingly for depression. And here it is for seeking psychiatric treatment. Much more likely to think that the person is going to do something violent if you're recommending psychiatric treatment than if you're not. So now let's pay a little attention to the implications of these changes from 1950 to 2006. Think about this power difference. And think about, I don't know if you can think about this, but people who have mental illnesses might be most troubled by these stereotypes of dangerousness and competence and the like. They're the group with the less power. The groups that might want to change the help-seeking, bringing people into treatment, are mental health professionals and the like, people with maybe more power. So let's think a little bit about this consequences for help-seeking. So compared to the 1950s and continuing into the period between 1996 and 2006, people now identify disorders in a manner that's consistent with medical conceptions. People have made dramatic changes in beliefs about biological and genetic causes that are consistent with a medical model approach. People are much more likely to suggest medical and psychiatric contact and have increased medical help-seeking for such disorders over time. People have increased their support of funding for treatment through insurance coverage or government programs. All of this is enormously positive for treatment seeking for mental health problems. We made dramatic improvements in that regard. What about consequences for stigma, stereotyping, and discrimination? We might have thought that a massive change from the social deviance to a medical view of mental disorders would have broadly reduced stigma. It has not. The best evidence indicates that the dangerousness stereotype has either intensified or remained stable in the midst of these other major changes. Similarly, inferences of incompetence have either not improved dramatically or have actually become stronger. Social distance has not appreciably changed for any of the disorders. Moreover, the beliefs that have changed dramatically, biological causes, mental illness labels, and psychiatric treatment seeking, are reliably associated with increased perceptions of dangerousness and decreased assessments of competence. So the news about these elements of public beliefs is not good for people with mental illnesses. So we've been enormously successful in changing public knowledge and beliefs about mental illnesses, but only in some domains. Core stereotypes of dangerousness and incompetence remain as strong and perhaps even stronger than they were decades ago. We can't address these problems through the messages we've already delivered, that mental illnesses are illnesses with biological and genetic causes that can be treated. Those are important messages in themselves, but they do not solve the problems of stereotyping and discrimination. That's a portrayal of public stigma. Now, I want to talk a little bit about how that might affect people with mental illnesses. I want to talk about 3 ways in which this might be manifest. First is direct discriminatory behavior by other people. A second is structural discrimination. A third is discrimination that operates through a stigmatized person. So evidence about discriminatory behavior by other people. There have been experiments by a guy named Page, had his graduate students call up available apartments and say, I'm coming from the psychiatric, randomly, I'm coming from the psychiatric hospital or I'm coming from the graduate school. Is the apartment available? Dramatic differences in whether the apartment's available if you identify as having a mental illness as compared to you don't. This guy Druss, this non-experimental studies, did studies of cardiovascular procedures after a myocardial infarction. He built on studies that showed that women and ethnic minorities were less likely to get the best kinds of procedures after a heart attack. And he was able to control for almost every aspect of the condition, showed that people with schizophrenia were also less likely to get the best kinds of procedures after a heart attack. Another way we can look at direct discrimination is to ask people who have mental illnesses. This is some items from Otto Wall that were asked of consumers, heard or others say unfavorable or offensive things about consumers or their illnesses. You see that they're relatively high percentages. I think when people think about discrimination towards people with mental illness, they usually think about those direct person-to-person kinds of discrimination. I want to talk about other ways that this can occur. And Perla did a nice job of actually talking about structural discrimination. And I'll just give a few examples that go along with it. Suppose that because schizophrenia is a stigmatized illness, there's less funding for research than for other illnesses, so we know less about how to prevent it or treat it than we would have known if it weren't a stigmatized illness. So less money to provide care and treatment given the knowledge we currently have. Schizophrenia and other severe mental illnesses are not covered by health insurance in the United States, for example. Treatment facilities are either isolated or confined to areas that don't have the clout to exclude this stigmatized group. So people with mental illnesses are sometimes placed in places where rates of crime, violence, pollution, noise, and infectious diseases are higher in these areas. And this is just the way things are. It's not like somebody discriminates to achieve these negative outcomes. It's just the way things have developed and are for any particular individual. And so as a consequence of developing schizophrenia, as opposed to some of the other illness, people get fewer of the good things and more of the bad things. And it just can happen even just because of the history of stigma, not any discrimination in the current moment. And then discrimination operating through the individual. Here what I'm going to do is describe a theory that I have, that people have called it the modified labeling theory. The idea here is that we all grow up in a culture and we all sort of pick up or learn how people think about people with mental illnesses, whether they think of them as someone that whether most people discriminate against a person with mental illness, look down on a person with mental illness, and then as a consequence of that, some of us develop mental illnesses and some of us don't. For those of us who don't develop mental illnesses, whether we think other people would discriminate or look down on a person with mental illnesses bears no consequence for us. We don't have that illness, it just doesn't matter in a way. But for a person who develops a mental illness, and then the possibility that other people might discriminate, that might not want to date, might not want to hire, might look down on, might take less seriously, becomes personally relevant. All of a sudden, that could apply to me. I've learned about it all my life. Now, it could apply to me. Now, that could be hurtful in several ways. First of all, I could feel bad that I'm in a situation like that where other people might discriminate against me. Secondly, I may develop coping mechanisms to try to avoid the discrimination. So like withdrawing, not trying for a job, not asking for a date, that could then end up hurting me in ways. And then finally, if I think that other people might discriminate against me, it might lower my confidence and actually affect my behavior in an interpersonal situation such that other people be less likely to want to date me, less likely to want to hire me. So I developed a set of questions to try to capture what people think most people believe. And here's some examples. Most women would not want to marry a man who's been a patient in a mental hospital. Most people think less of a person who's been hospitalized for a mental illness. Most employers would not hire a person who's been hospitalized for a mental illness. There's 12 of these. And then the idea here is that this is going to be broadly shared across society. This is a study, I won't go in much depth, but it included both patients and people from the community who had high or low symptoms, and pretty much everybody has the same view about whether most people will look down on, not want to date, not want to marry someone with a mental illness. And this leads to this set of hypotheses. Down here is perceived evaluation discrimination, and this is someone who doesn't develop a mental illness, never goes into a mental hospital. They can either believe this strongly or believe this less strongly. It has no implications for their how they function in jobs, social networks, or their self-esteem. It's a flat slope. But for people who do develop a mental illness, do enter a psychiatric hospital, the more they believe this, the more of a threat it poses, and the worse that they're likely to do. And here's some results that are consistent with this particular theory. It's been connected with unemployment and income loss, social networks, quality of life, depressive symptoms, delays in help seeking, and in self-esteem. So here's some conclusions about the current state of stigma. Core beliefs about the nature and causes of mental illness have changed in ways that will facilitate help seeking. Core stereotypes about people with mental illnesses have not been changed. The resilience of these stereotypes ensures enduring problems for people with mental illnesses through interpersonal discrimination, one person doing something to another, structural discrimination, as I described to you, and discrimination that operates through the individual, like this modified labeling theory I just told you about. A strong and effective response to the stigma and discrimination associated with mental illnesses lies before us. Thank you.